Well, good morning to all of you. Thank you so much for that introduction, and I really appreciate the opportunity to be here in Missouri and to talk to you a little bit today. How many of you are in the crisis services field? You're doing mobile crisis, any mobile crisis folks out there? Crisis call centers. Or you're in a community mental health center that runs a crisis stabilization program, crisis respite program. How many of you are clinicians or social workers by background? Okay, so most of you. So I'm a crisis junkie, if you will. I am a licensed professional counselor who's been doing crisis work for many years. I started off going. How many of you ever held the pager? Did any of you guys, that I still have a little bit of the heebie-jeebies around a 2 a.m. What's that vibration? And getting up to go in to get in the car and drive to Redmond emergency room, which is about 45 minutes away, and complete an assessment and come back. After that, I've worked for systems of care and managed crisis systems. And I'm going to assert to you that the era for crisis services is now. We started with the unspeakable tragedies in Virginia Tech, and then in Columbine. Those go back to 2007 and in that time frame. And flashing forward through Tucson and Aurora, which you're looking at the movie theater in Aurora, Colorado. More recently, Newtown, the Navy Yard. We've gotten almost into a news cycle where the moving through the stages of disbelief and hand-wringing to going back to life as normal has sped faster and faster and faster to the point that it's almost a blip. And yet at the same time, the government and the public are really looking for us to do something different. And so I'm going to start with a polling question. The question is, Virginia Tech, Columbine, Tucson, Aurora, and Newtown. We should do the following. A, we should double the mental health capacity in the United States. B, we should immediately eliminate assault rifles. We should ban them. C, we should dramatically expand training like mental health first aid. D, we should create a robust and integrated crisis system in every location across the country that doesn't currently have one. D, we should do all of the, or E, we should do all of the above. Or F, we really shouldn't do any of those because these events are unavoidable and they wouldn't make a difference anyways. How do you respond when you see these? How many E's do we have in the room? Fair number of E's. I think we all probably started out in E. I don't know that that's going to be a tolerable position going forward, and many states are saying it's not. The first four actually come from, or the first three come from a letter from Ron Manderscheid and the Association for Community Mental Health Management, as well as others, NAMI and Mental Health America, who talked about doubling the funding, employing the assault rifle ban, and mental health first aid. But others are seeing that we should be doing more integrated crisis services, and we're going to talk about that. So it's all of the above. We're looking at this technically, we're looking at this politically, we're looking at this symbolically. The nation is saying we must do something, and crisis services, you'll see, are part of that solution. So we've got 55 years now of crisis services. It really goes back to 1958 when Ed Schneiderman started the first suicide prevention crisis center in Los Angeles. And that center is still there today. It's known as D.D. Hirsch. It launched all kinds of initiative over time. The American Association of Suicidology really came out of what was that original Suicide Prevention Resource Center. They now have some really innovative resources, including suicide attempt survivor support groups, and continue to be an agency in this space today. How many of you are familiar with CIT? Do we have CIT in Missouri? So in the late 80s, early 90s, there was a shooting of an unarmed individual who was an African American and had mental health issues in the city of Memphis. He was shot by a group of white police officers. And the city at that time said, we have to do something to respond in a stronger way. What can we do? A collaborative was formed of the local NAMI and the police department there in Shelby County, alongside researchers from the University of Tennessee. And you see Major Sam Cochran and Randy DuPont from the University of Tennessee, who were really the pioneers behind that, with the energy and cheerleading and support out of the local NAMI and the holding them accountable to create something that is now in jurisdictions across the country to train law enforcement about a more humane, respectful, engaging response. It's basically a 40-hour training. They had their international conference in, I believe, Connecticut just this last week. And it's in jurisdictions across the country where law enforcement officers are receiving a mental health primer, somewhat like mental health first aid, but they're also receiving generally about 16 hours of crisis de-escalation, and they're doing role plays, and they're partnering with local community mental health providers and working to make a difference. So you're going to see a theme. We started with that Aurora incident. I understand where all of you who answered E are coming from, and yet you'll see these themes behind these implementations of crisis services. We've got behavioral health response here. They were formed for almost a reverse sort of incident, but also coming out of an incident of violence that occurred from an individual with severe mental illness and a couple of family members who were killed. A behavioral health response, it was, I think initially 5 community mental health centers came together, were the board of directors for that organization, and one of the first professional, what I call niche models. It's an agency whose core service is mobile crisis access, triage, and employs high technology and clinicians, professional clinicians, to do this work in close coordination with community mental health. That's something you've seen that's different. In this timeline, as you notice the timeline, there's a big jump between 1958 and 1988 and then 1995. During that time, there were hosts of call centers that came up, mobile crisis and certainly crisis stabilization. But by and large, those entities worked in isolation and were fragmented. They were either small and volunteer and not connected to community mental health, or they were under community mental health but a secondary or tertiary business and not attached to others in the community in significant ways. And behavioral health response was really one of the first to break through that. So let's now talk about a community mental health sort of model. Harris County is Houston, Texas, and it's one of the most robust models under a community mental health center in the United States. And the leadership there is actively engaged in the national dialogue at conferences and presentations. And you can see on the board there the array of crisis services they have, including a psychiatric emergency department, for those of you who are familiar with those models in a large metropolitan area of the United States. In 2006, the state of Georgia took a concept that was previously called single point of entry and expanded it to the entire state, all 159 counties. And the Georgia Crisis and Access Line, similar to Behavioral Health Response's call center, engages individuals from the community. They're people who are calling for their own mental health, addiction, suicide, or other sorts of social issues that they're calling about in crisis. Or it's a family member, it's a loved one. It's the mother, it's the daughter, it's the brother, it's the spouse who's calling for a loved one, a friend who's seeking help, or it's a host of social services, emergency departments, probation officers, juvenile justice, judges, courts, et cetera, who are calling to engage supports. Support around, number one, an assessment and triage of risk and need. What do they qualify for? What payer source do they have? What's their age? What's their disability? What are their needs? What's their level of intensity of need? And then what is available to them? And then the Georgia Crisis and Access Line, part of that contract was it had to actively in real time, 24 hours a day, be able to connect with and electronically schedule appointments and measure all the data around the average time between that appointment. So for outpatient, they have a metric called average business days till appointment, which is for all several hundred sites across the state. They measure that in real time. For all of the intensive services, crisis stabilization programs, detoxification, inpatient hospitals, it's not days, but minutes, average minutes till disposition. The metric is minutes. Sometimes the weights are not. All of that information is available. If you go to actually Behavioral Health Link's website, they have dashboards that have those metrics on them. But it was a really response to Hurricane Katrina. Now, you don't typically think of Georgia. When you think of Hurricane Katrina, you think of Mississippi, Louisiana, and to some degree Texas. There were 20-some-odd states that received individuals who evacuated from Louisiana and Mississippi. Georgia was the second highest. It had 120,000 people that came into Atlanta, and it really exposed some of the weaknesses and challenges of the quote-unquote crisis system at that time and led the state to make a significant change. Now, I worked for Behavioral Health Link in fair disclosure, and I remember a time when people, if they were studying crisis services and wanted to do something innovative, they would go to Behavioral Health Response, they would come to Atlanta. Later, they would go to Harris County. Today, they go to Tucson. Have any of you been to or heard of the Tucson facility? Tucson is a result of a couple of bonds worth $50 million in the Tucson community to build a single facility that integrated with the co-located University Physicians Hospital that has a psychiatric inpatient unit. This facility that you're looking at has crisis stabilization and detoxification. It has a embedded crisis line, has peer-operated warm line. It has co-located community mental health providers. It has a large sally port so that when law enforcement come in, it's just like in a prison or a jail, but it's around safety. And it's all under one roof in a pretty amazing facility that started, the whole process started in 2006, but the facility did not open until 2010. Now, that facility in Tucson is off of the interstate there in a relatively smaller community as compared with a St. Louis or a Houston that we've talked about, or an Atlanta, or a Phoenix. In Phoenix, they have a managed care carve-out, or have. Magellan Health Services has been responsible for the last 5 years. That was my role. I was the director for the clinical system in Magellan. It's a $750 million contract to provide the full array of services from peer-operated warm line, community mental health outpatient, all the way up through to pharmacy and psychiatric inpatient acute care. In that contract, they have a host, what I would call a full array, all of the stair steps of crisis services. In many rural areas across the country today, you still have two basic options. You have outpatient, and you have whatever the top is. We could call it inpatient hospitalization maybe, or incarceration, and avenues to get there through the jail, the law enforcement, 911, or the emergency department. But people's needs fall along there's a full set of stairs before you get thrown all the way to the top, or all the way to the bottom if you want to look at it that way. And in Phoenix, a group of community collaborators, it was a group about the size of the people in this room, both at Magellan and community providers and crisis providers and law enforcement and other community stakeholders, individuals and families receiving services. They identified that even though there were a lot more services available in Phoenix than in most rural areas, there was still a gap in the middle. And what you're looking at here are the access point, transition point facilities operated by Community Bridges. They are 24/7 outpatient sites that you can walk into at any time, day or night, without being a client enrolled there. And they have co-located. Now, in the licensure, you actually have to go out the front door and in another door, but it's in the same, there's a wall between. But they are co-located with short-term residential facilities. So it became, for us, the stair step that was missing in the middle of the continuum. And then that we have them in geographically located. So there's not only the stair step is there, but there's sufficient space on that stair step for people to stand. Because if there's somebody occupying the stair step, then it's really not available to you. Now, on the Magellan website, they have a dashboard around crisis services, an outcomes dashboard that talks about wait times and throughputs and that kind of thing. In that dashboard, you'll see a hierarchy. And the upper end of that ladder, if you will, are services you're familiar with: acute inpatient hospitalization, psychiatric subacute and detoxification, 23-hour crisis stabilization. And then you'll see below the dashed line there the level 3 time-limited residential and 24/7 walk-in outpatient, which are the service that were added. And then the lower end of that continuum, mobile crisis teams that also go to hospitals, that go to the community, that will go to a homeless person on the street or into an apartment or a social service agency, as well as crisis hotlines, and then even lower levels of care, peer navigators who can meet individuals in social service agencies or connect with them at crisis stabilization programs, as well as peer-operated warm lines. And in the view of Magellan and Phoenix, all of those stair steps have to be available and with sufficient geographical accessibility and capacity if you're going to effectively provide crisis services. Now, in Phoenix, I mean, we're talking about approximately $150 million that goes into all of those services, and yet the impact of that, if you take those services away, not only do you not have the supports and recovery-based interventions that are going to help individuals, but you're going to have those individuals go where? They get pushed into a stream. And the water in that stream has its own current that doesn't depend on which direction that person is swimming. Have you ever noticed that? How many of you have been into an emergency department and you've given a clinical assessment and recommendation to a physician, but there's a current flowing, and you get moving with it if you're not careful. And it goes toward higher end, more liability conscious, risk averse, higher cost, higher intensity, higher intrusiveness as well. And that leads us to Colorado. So Colorado is the most recent of these, what I think a year from now will be one of the most significant crisis intervention efforts in the country, and it is specifically in response to Aurora and Aurora on top of Columbine. But the governor and the legislature appropriated $18 million a year in order to provide statewide a full continuum of crisis services, including peer warm line, crisis line, mobile crisis, 24/7 walk-in, crisis stabilization, and crisis respite. And to have it on a statewide basis that would be available to all. So these themes, these trends are going to continue. So if the age of crisis services is now, why is it? Why is that? What's occurring? What are the factors that are influencing that and leading us to where we are? I think this statistic was a little bit surprising. Recently there was a survey done that was published in the Washington Post, and it reflected a change. This is not the way the American public looked at this after Tucson. After Tucson, we reached a level that even in a country that values the Second Amendment and the way the amendment, we began to think about gun control, and then we began to move away from that. And what you see now is the American public believes the primary way that we could solve these crises is through better mental health system. That's what's beginning to emerge. So, polling question number 2. Without community-based mobile crisis services, law enforcement and ERs will hospitalize individuals, the same amount as if those services were available, and I'm talking about mobile crisis, community-based mobile crisis. Without mobile crisis, they would be actually less likely to hospitalize. That's to say that mobile crisis would increase hospitalizations because you've got mental health professionals coming in who can do a better triage and assessment. C, law enforcement would be twice as likely to send someone into a more intensive service and ERs, and answer D, 3 times more likely. So, normally I like to do this with the monitor, where you put the little remote and it shows up on the screen, so you don't have to kind of out yourselves. But in the absence of technology, we have to out ourselves. So, answer A, same amount. Any A's in the room? Anybody believe that it would be less? What about C, 2 times more likely? Any D's? 3 times more likely. The answer is 3 times more likely. We've been doing research, studying research, and also tracking data around this for a number of years. And basically what you'll find is in the absence of these community-based mobile crisis services, 3 out of 4 individuals with mental health issues and addiction issues that show up with law enforcement emergency departments will be washed down into more intensive services. Not all. 1 in 4 will not. You put community-based mobile crisis services in place and it's the reverse. About 75% will land up being released to less intensive natural supports, other levels of care, and a quarter will go. So we talked about Colorado and its 18 million and the most robust scenario that we've seen so far. Well, let's go a step further. California has now passed legislation, Senate Bill 82, which appropriates $182 million to crisis services. That they've already started the process of bidding that out across their 54 counties in California. But Senate Bill 82 actually found that 70% of people taken to ERs for psychiatric evaluation can be stabilized and referred to a less intensive level of care. And so they are coming at this not from the same public safety, although that dynamic is there. They're coming at it from a cost standpoint. They believe there's way too much money spent on these services for acute care and incarceration when individuals could be served at lower levels of intensity if the appropriate vehicles were there to connect them. So what do they want? They want 2,000 crisis stabilization and residential treatment beds that they don't have right now. They want 25 areas where they have mobile crisis support teams and additional 600 triage personnel. So you'll see this, again, taking this to an entirely new level. It's basically equivalent to what Colorado's doing in all of those humongous population counties in California. Now, that's not the only dynamics. We've talked about the public safety issues. The American public and our policymakers and our legislators and governors want more robust crisis services because they believe it's part of a solution for the events we've seen. We see governments that are also in the age of the Affordable Care Act looking at the impact of cost savings. But there are other factors around the Americans with Disabilities Act. So the Bazelon Center here, you see, has a website talking about the fact that the Americans with Disabilities Act also applies to mental health. And you're seeing now the Department of Justice this is a shot of their website from the state of Georgia. They've been in Delaware. They're in a host of states around the civil rights of individuals in institutionalized facilities. And there's a settlement, actually a couple of settlement decrees with Delaware and Georgia and others, where they're looking at individuals who have been in institutions who could have been released to community services but weren't for a host of factors. And typically these consent decrees are including things like statewide crisis and access line, community-based mobile crisis, enhanced crisis stabilization, same thing. Now, we talked about the crisis field being one that for many, many years was very, very fragmented. I would say it's still exceptionally fragmented. But there is an example I'd like to talk briefly about, and that is of crisis hotlines. How many in the room operate a crisis hotline? Just BHR? Okay. One other one? So crisis hotlines across the nation, there are approximately 150 or so that are in the National Suicide Prevention Lifeline Network. There are probably another 150 to 200 that are not in that network that represent a group of several hundred crisis centers that up until the late 90s really had no what I would call professional orientation. They didn't have an association. They weren't together, working together, learning from one another, establishing standards and protocols, doing research on what they were doing, looking at legislation to support their work together. They were frequently operating on their own and learning what they could from other call centers, from 911, and and doing what they could, but without a lot of support, and in fact, I remember I ran a crisis hotline during the late 90s, and I remember that I would go to coalition meetings for suicide prevention in the state that were the stakeholders, policymakers, family members who wanted to end suicide, for example. And they would make statements that crisis centers really are a waste of money. Why did they think that? What was the view that led them to believe that that was not a strong investment of funding? I saw your brain. So, a couple of reasons. The first is they thought that truly suicidal people and people in real crisis didn't call crisis hotlines. They thought that the way one woman told me was that she thought middle-aged little old ladies with dysthymia and poor social connections called crisis lines. So there was a lack of data around the actual utilization. There was a lack of research about the outcomes. And there was a lack of credibility about what they did. And so it was unknown. And those views still persist at times. But in the early 2000s, 1-800-SUICIDE and the American Association of Suicidology through SAMHSA came together with a national grant, a national number, and began for the first time to put together what I would call professional orientation, an association, camaraderie. We started meeting with BHR and learning from them. And maybe even they learned something from us and other companies like Protocol Services out of Portland and Harris County, some of these same companies we're talking about. Boys Town, we began to meet some of them. And then in 2005, that grant was recompeted, and the Mental Health Association of New York City won the grant. You see Dr. John Draper on the screen. And they took it to an entirely new level of steering committees and collaborative working groups, trainings and practices groups and peer groups that began to develop standards, began to put forth protocols, began to do formal and rigorous research, began to market about these, and the credibility in a single decade dramatically flipped because you had data about who was calling. Wow. It was little old ladies who had dysthymia and needed social supports, and a host of other people with very significant risk, and the outcomes of that were monitored and measured through research done out of Columbia University and Rutgers and Montreal and et cetera. And it really led to an entire new approach around crisis call centers. Now today, I would say mobile crisis services, crisis stabilization, crisis respite, are in the same place that call centers were a decade ago, 15 years ago. There's not an association. They're somewhat fragmented. They're doing their best to come up with standards. But the learning opportunities for us to engage together and drive this forward, you're starting to see it. It's happening. Funding's starting to come. Collaboration's starting to happen. That professional orientation is starting to develop. So what did the National Suicide Prevention Lifeline do? Well, the very first thing it did was it established a set of suicide risk assessment guidelines, a way to evaluate what is the relative risk that someone has when they call or are contacted by a mobile crisis team. What are the factors that go into that? And the first thing you can see on the screen, they recommended 3 basic questions. Are you thinking of suicide? Have you thought about suicide in the last 2 months? Have you ever attempted to kill yourself? And those 3 basic questions, it seems very straightforward, and yet when you look back at that network of 150 crisis centers prior to these guidelines, in half of them, those questions were not asked at all. And the view was, if someone wants to talk about suicide, they need to bring it up. Let's not bring it up for them. Now, I get that view from, I don't agree with it, but I get that view from outpatient community mental health. I'm not sure where that comes from. You call the local, what is marketed, it might be the local crisis line, marketed as a suicide hotline, and yet the staff won't bring up the issue of suicide unless and until the caller brings it up first. But that was the view at that time. And then there was a set of key areas that needed to be assessed: the capability, the intent, the desire for suicide, and buffers and connectedness that would occur. Now, those standards were developed by a joint group of crisis providers, community mental health, family members, researchers, and policymakers, were codified and approved by SAMHSA and released. What did that do for the field? Well, it gave it enormous credibility. And in fact, I was in Belfast, Ireland last November visiting the local call center, and I looked up on the wall, and guess what they had right there? It was all of their key protocols, including the suicide risk assessment standards that are now impacting practice across the world. And then you create a learning community. When Crisis Center in St. Louis realizes, wow, there's buffers and connectedness piece needs to be augmented, and that's shared with the group, and the group coalesces around that, then everyone benefits from that change. Again, that's what I would call professional orientation. Polling question number 3. People have a right to suicide. We should do everything possible to engage someone at risk, but not invasively intervene if they do not want our help. Strongly agree, strongly disagree, and everything in between. Feedback from the group without kind of asking for a show of hands. Yes? So there's enormous ambivalence, and the opportunity to engage them effectively means that we should do whatever we can, is what you're saying. Other views? Okay. So we've got a couple of views that we should do everything possible. Anybody want to take the contrary view before we move along? If you do, you'd be a brave soul given the theme of where this presentation's going. Actually, I've given that particular question in a survey to about 30,000 professionals across the country in public sector community mental health. We've done that in 9 states now. And Utah just finished up last week. We had 8,000 social workers, counselors, teachers, peer staff, etc. take that. And they struggle with this question. And I asked it for a purpose, to make them squirm. Because we get we're social workers, we're counselors, we like to process and think about things from all different angles. And I don't. This is we are all, if we're in the field and working at community mental health or a crisis center or a medical facility, then we've got an obligation to do no harm, and we have an obligation to keep people safe. And so because of the very reasons and others that we've talked about, we have to do whatever we can. Now, again, while that seems like a given for kind of medical and behavioral sorts of settings, there were a host of crisis centers, and are still some today, who don't take that view. They take the opposite view. Now, I've tweaked it a little bit for the sake of a presentation. I think they would take the view that I want to have anyone who calls us have ultimate trust in calling us. And that means you're never going to have us do something that's intrusive or invasive or have law enforcement show up at your door. And so I get where they're coming from. And yet, for the reasons you're talking about, I think it's a both and. We want to do that as minimally as possible. We want to engage and collaborate and bring people along however we can, and then do what we have to do if that doesn't work. So the Lifeline developed a protocol and a standard for emergency intervention, what some in the field called active rescue. The first thing they had to do was define imminent risk. That had not been defined at that point. The view was that it could not be defined. That view continued throughout our steering committee meetings, but we ultimately did come up with this definition. And the researchers in the room hated it because well, read it and you'll see. The staff believes the person's current risk, status, and actions could lead to suicide or the death of someone else. The staff sense an obligation or immediate pressure to take urgent actions. The individual has both a desire and an intent to die and has the capability of carrying through. Now, crisis services are much more than suicide, and yet the National Suicide Prevention Lifeline, this is their core mission, so you'll see the focus here is on suicide. And you sense that what they're doing is developing, it's somewhat vague, but it has to do with the sense of the clinician about risk and the immediacy of it. And in fact, this is similar to other standards that we have and have seen even more so in the age of public safety, terrorism, and other things. The immediacy of a situation, the assessment of obligation and immediate pressure. And what was developed after that was a set of 9 guidelines for emergency intervention that start with the active engagement. We felt like, for the very reason that some centers don't want to do this at all, that the collaborative, engaging, relationship focus has to be paramount. We have to be doing everything possible to avoid these more intrusive and intensive interventions. There are other things. I won't go through the whole list. Initiating life-saving services for attempts that are already in progress. Again, it's kind of stating the obvious, but if a center had the approach that they would not do that, there are individuals who call crisis lines who've already made what will be a lethal attempt without intervention. And sometimes individuals call a crisis center who've made a lethal attempt that is not going to be overcome. It's too late. So those kinds of events do occur, and staff have a protocol around how to do that. It also required caller ID. Not all call centers at that point had the ability to trace where someone was. That's of course become more complicated in the age of voice over IP, as well as confirmation of emergency services contact. So two issues here. One is, prior to these standards, the basic approach was this individual needs law enforcement. We call and connect with Fulton County Sheriff. They're on the way. We move on to other calls. This new standard required a circle back to confirm what happened next. Did they in fact connect with them? Where did they go? The other thing it required was a new approach to third-party callers. The common practice in the field prior to these standards were that if Bart called me for himself, then I'm doing everything to help him. And I'll send law enforcement if I have to, if everything else doesn't work. If Pat calls for her friend Bart, we're going to encourage Pat to call 911. That was the old practice. The new standard said that's a cop-out, and the responsibility and obligation is on the call center to go, again, make an assessment of risk in the same way that you would with anything else. This is my one shameless, these are my 2 boys, and the issue of 2 together, engaging and collaborating as opposed to kind of that top-down law enforcement, a professional and underling sort of. We're trying to jump in, work with somebody, solve a problem together, and to avoid. This is from a research study on follow-up and feedback. The person said from the very beginning, I felt like she, the call center worker, was an ally. It felt safe to really, really open up to her because she accepted me as I was, where I was, listened to me and heard me, felt like she was a partner working with me, and it felt safe. The power of those collaborative, engaging approaches is pretty significant. So, polling question number 4. Individuals in crisis often feel out of control, and seclusion and restraint are appropriate treatment interventions that help reduce anxiety and provide safety. I see some smiles in the room, wait a second, I'm on to him. I know where he's going. Comments or feedback about this before we move on? Appropriate interventions that create, that reduce anxiety and create safety. Agree, disagree? Say more about that. Yeah. So let's talk about what we've learned over the last several years. How many of you have been engaged in a trauma-informed care training, either at your agency or at a conference? Okay, a host of people in the room. And if you haven't yet, you will be. The field is making a dramatic shift and saying, wow, we've said way too often, what's wrong with you and way too infrequently what happened to you. And as we're studying and getting feedback from in particular the ACEs surveys, it's uncanny the outcomes related to past trauma, neglect, abuse, lack of connectedness, those kinds of things, what they do to individuals, not only behaviorally, not only from a mental health and addiction standpoint, but actually COPD is directly, it's not just correlated, it's caused by some of these same sort of situations. This is the cover of the National Council magazine a couple of years ago around trauma-informed care. And we're beginning to think about all of our services as they relate to, are we creating safe, nurturing, supportive environments for individuals who are experiencing issues that many of them are experiencing those issues in large part because of trauma that they have previously experienced. So seclusion and restraint. In the year 2000, Charlie Curry, who was the administrator for SAMHSA for many years, but before he was that, he was in the state of Pennsylvania and with the state hospitals there, ran an initiative to begin thinking about seclusion and restraint differently. To begin to say, maybe this is a treatment failure as opposed to a normal intervention that we should be using. Now, that's not to say that it can't happen or should not happen when all other things have failed, but we should view it differently. We should look at it as if we didn't do something right, not the individual. And we should debrief about it and think about it and do even a critical incident review on it. It won the Harvard Innovations. I mean, this is thousands of applications across the country from all sectors, local, federal, and state, from every possible Homeland Security to transportation and education. This was one of the top awards in the year 2000. This is the Recovery Response Center. It's a crisis stabilization center in Peoria, Arizona. It's operated by a company called Recovery Innovations. And it was one of about 7 major facilities that I was responsible for when I was at Magellan around crisis stabilization or detoxification services. And we tracked the number of seclusion and restraints that those various facilities would perform. And some of the facilities of the size and scope of this facility would do several seclusions, restraints, forced medications per day. 2, 3, 4, 5 a day. Whereas this facility would frequently do 2 or 3 or 1 or sometimes 0 during the whole month with the same clients, the same level of acuity. And it really made me wonder, what is different about that facility? Well, they use an approach that's known as no force first. And it's basically just taking this concept that Charlie Curry pushed forward to us and pushing it further and formalizing it as an agency, that our policy is no force first. We're going to define it. We're going to have a policy around it. We're going to train people. We're going to support them. And we're going to report on it. And when a seclusion, restraint, and forced medication occurs, we're going to sit down later with the staff and with the individual service recipient and process that out. We're going to do a critical incident debriefing about it. And their outcomes are far superior to anything I've ever seen before. Now, they do a host of things. They don't refer to individuals as patients or members or consumers or anything like that. I think they call them visitors while they're there at the facility. They don't have any numbers on any of the doors. The rooms are called like Recovery and Resiliency and Rejoice. They all start with R. The facility itself is just a spectacular facility. Everything about it is just open and welcoming. And so I have assumed for the last 5 years that the reason they had such lower levels of seclusion and restraint had to do with more respect, engagement, collaboration, culture, and yes, those are all true. But I was visiting the facility with the state here recently. We were there for several hours, just going through the whole thing top to bottom. And what became clear to me is they do all of that, and they accompany at every single point a peer in the process. So when law enforcement comes in to the back secure area and drops people off, they do the same thing every other crisis stabilization program in the country probably does. They have a nurse and a physician that meets the person and does an initial assessment before they come into the environment. But before that nurse and physician meet them, the very first person they meet is a peer who kind of orients them to the process and what's going on. And the physician and nurse come in then. So there are peers baked in and engaged at all points of care and part of that treatment team in significant numbers. So let's talk about follow-up and what I would call the chain of care. Another major theme that's going on in crisis services right now that came from psychiatric inpatient was a study from the New Zealand and Australia area from researchers Jerome Motto and later Annette Botrace and others around follow-up. And basically, they sent a letter to individuals who had been in psychiatric inpatient, and they would send them to them at regular intervals. So there was I think an initial letter and then one at 6 months and like 2 or 3 letters that they got over the course of time that are basically form letters that say, we're thinking about you, we want to make sure that you're okay, here are some of the services you continue to avail yourself of, but a basic kind of form letter follow-up. And the striking thing about this research was that it made a difference in reducing reattempts at suicide. Wow, a form letter made a difference. So the researchers in America, specifically Madeline Gould out of Columbia University, is now studying through a SAMHSA grant, what if crisis centers made follow-up calls? Again, think about that the old approach of crisis centers was touch, engage, connect, and move on. Well, if they connected. Sometimes it used to be refer. But then connect and move on to something else because there's a lot of people calling. And now the expectations are really moving toward some kind of follow-up. And what they're finding is really phenomenal. It speaks to a little bit. If I'm the crisis call center worker or mobile crisis, and you come in, I see you, and I'm empathic, and I'm collaborative, and I'm engaging. You say, yeah, that was helpful. B+. Because in the back of your brain, it was helpful, but he does get paid to do that, doesn't he? I mean, it's kind of his job, so I don't know if he cares about me, but it was helpful. Now, 2 days later, I call you and say, hey, I'm just checking up, wanted to follow up. We saw each other a couple of days ago. I do the exact same thing. But the interaction originated with me this time as opposed to you, and A+. I love that. Boy, that was caring. And why is it so different? Well, the actual outcome and perception is put on steroids when the direction, the energy changes, moves the opposite way. Even in something as sterile as a form letter, it's making a difference. We're seeing as humans are contacting, making outreach calls, we're seeing really significant results. 54% in the follow-up study that Madeline Gould has done so far have said that that follow-up contact has helped the individual not go forward and in their life. About 90% have said that the call was helpful. So there's a lot of research about follow-up that we think will move into crisis stabilization, mobile crisis, call centers, etc. Richard McKeon is the branch chief for suicide at SAMHSA, but he is an individual who ran in New Jersey a fully integrated crisis system before he came to SAMHSA. So within the hospital community mental health agency, they had the full gamut of crisis services, mobile, inpatient, and he ran that. So he really comes at it from a standpoint where connections of care are a given. And what we've seen over the course of the last decade as professional orientation has begun to happen is we've seen scenarios where a psychiatric emergency department or a emergency department with psychiatric resources is sharing a flyer with everyone who comes in with a mental health issue. And this flyer was sent to Richard because it had like 15 or 20 resources on the flyer. And the person had gone through and checked, and there wasn't a single number on the flyer that was still accurate. So what was happening is there was no view of referrals being made to individuals with behavioral and addiction issues that were coming in. There was no view at all of how many of them connected with the service. So the chain of care was totally disrupted and broken. And so this opportunity of crisis services to connect and engage is another significant issue. The other area I think we'll see most played out in crisis services over the course of coming years is the potential of technology. The Veterans Administration has one of the most innovative approaches out of their Canandaigua call center in New York. It's a veterans hotline. If you call the 1-800-273-TALK number nationally, and you have an opportunity to press, I believe it's press 1 if you're a veteran. And that takes you through to a network of call centers, but the first stop is Canandaigua. Now, traditionally, you've been able to call that center. Today, as you look on here, they encourage you to text or chat, take a self-check quiz. The self-check quiz then integrates with business rules that encourage the individual to chat. So the opportunities, the vehicles that are available for us to connect with individuals are expanding. We originally thought people would stop calling and they would chat or text instead. Nope. The callers still call, and a new group who didn't contact us before is texting, and another new group is chatting. So it's just increasing the overall reach. I mentioned the Georgia Crisis and Access Line earlier. The Georgia Crisis and Access Line is using technology to connect all of these providers together through secure web interfaces through an air traffic control. So as individuals are touching any point in the system, whether it's an emergency department, a social service agency, law enforcement, or calling in, they're then routed through the system wherever they are at various points. And stakeholders at the state, the health department, at the receiving end, inpatient facilities, crisis stabilization, all that is tracked and routed. So what are we waiting for? We're waiting for a medical clearance. What does that mean? Well, it means we're waiting for a particular lab, and you can see it in the software. So again, I think the opportunities with technology to solve some of these issues around engagement and around chain of care are going to be expanding as we go along. This is just a brief view of the various ins and outs. You're seeing the outs. Where did the referrals connect with? And you can see, for an example, let's say 10,000 or more. The agency has made more than 10,000 connections with Highland Rivers Community Mental Health Center. I think it's actually in the 20,000s that have been direct connections where that chain of care is followed up, and that's done through technology. So in addition to that, I think that where we started was the time for crisis services is now. And the professional orientation, the opportunity to learn together and to weave together agencies that are core crisis services providers or agencies who have a community mental health outpatient mission, residential services, other services, where they also operate a crisis stabilization program or a crisis respite program, but it's secondary to their core mission. There's a host of different types of agencies who operate from peer-operated or crisis lines all the way up through facilities, and some like Harris County who operate all of it. Those entities we want to start to bring together. So this coming year at the National Council Conference in May in Washington, D.C., there will be a first ever track, a special track for crisis services. We're going to have networking opportunities, a host of presenters. We're going to be bringing in some first-rate kind of keynotes to help guide that. And it will be really the first effort at bringing this together, not in a niche way under like where crisis call centers or those efforts have certainly occurred before, but for all who are doing crisis services in any kind of material sort of way. We're also developing a steering committee. Suzanne Rabideau, who's the Director for Crisis Services in Tucson, that facility I showed earlier. Pat's been a part of that effort with BHR. If you haven't been see one of us, we are happy to give you more information and look forward to where that effort goes as we move forward. So any final questions or comments? So thank you very much.